All right. So good morning, everybody. So welcome to our emergency department POCUS grand rounds. Today, I don't think it'll be a particularly long one today, but I'm going to just go through a couple of cases this morning. The first case I'm going to go through will take a little bit longer with and go a little bit deeper on. And then at the end, just a couple of quick, fun ultrasound cases that have just been lovely, neat, and show us how useful POCUS can be in the ED. It's a bit of a, pat ourselves on the back moment. And then we've got grand rounds afterwards, which again is a nice, neat little study. All right, so we'll get started. So this first case is a 50-year-old lady who had an out-of-hospital cardiac arrest and came into ED within the last month or so. I'll say from the outset, this lady did not have a good outcome, unfortunately, but it was an opportunity for us to capture some echo images at rhythm check during her arrest in ED, and where we found some interesting pathology that made me think about the pathology itself, but also how it fitted into the bigger picture. So we'll go through that case and do a bit of learning. So this is, as I said, is a 50-year-old lady who had an out-of-hospital cardiac arrest. She was fairly comorbid with end-stage kidney disease, pre-dialysis, had leukemia in the recent years and was currently in remission, type 2 diabetes, and had a really prolonged ICU admission at the Alfred last year for some necrotizing fasciitis. So she was not a well 50-year-old lady. She had a witnessed arrest at home with quite a prolonged downtime pre-hospital. She was initially in VF on AV arrival and had one shock and some amiodarone before she then went into PEA for about 10 minutes, they estimated. Subsequently went back into VF and had at least 10 shocks delivered prior to achieving ROSC pre-hospital. And they estimated at least 45 minutes of CPR before arriving in ED. Her family subsequently reported that she'd been having increasing peripheral edema over several weeks, but was otherwise her usual self on that day. When they did achieve ROSC, there was an obvious inferior with possible posterior extension STEMI on her ECG. The cath lab was activated pre-hospital, was not yet ready on her arrival to ED. And in ED, she was intubated. She was on an FiO2 of 100% with quite high pressures to ventilate and achieving SATs of 74%. She was on an adrenaline infusion at 50 mics per minute, and on our initial assessment was found to not have a pulse, and CPR was commenced again. There was a non-shockable rhythm on her first rhythm check and upon all subsequent rhythm checks. So we, within the first few minutes of her arrest, we captured this image, and then I'll show you the second one after that. Hi, Jake, welcome. So this is, Jake, I'll just give you a quick update, just having joined us. This is a lady who's had a pre-hospital cardiac arrest with a prolonged downtime of about 45 minutes, a combination of VF and PEA, and rearrested upon arrival to ED. And this is a subcostal view just during her arrest in ED. And Jake's probably very good at doing these and probably does these more than we do. All right, so this is the first one. So we got a couple of seconds only, and then I'm going to show you the second one. Okay. Would anyone like to offer any interpretation of these images? Shall I pick on someone? Ezra.
Oh, I thought I'd give it a hand.
Thank you.
It's a very nice capture of the right ventricular free wall collapsing. And the left ventricle looks very hypodynamic as well. There isn't equal contraction of the septum doesn't squish, and the posterior LV wall doesn't squish as well. And the mitral valve, I couldn't really see it, but I don't think it's approaching the septum. the picture's not very good.
No, I didn't really capture a good view of the mitral valve. I agree.
Yeah. So there's LV failure, and there's evidence of tamponade from the RVRA collapse.
Yeah, that's right. So that was our feeling as well. Our feeling was that, yes, we've got significant LV hypokinesis, but there is a pericardial effusion present. And I showed that first image just because even though it was terrible, this first one, in terms of technical capture, you could see that pericardial fluid as I scooped sort of posteriorly, then anteriorly. And you can see it again on this second image. So the findings were, yes, we've got coordinated cardiac activity. There is pericardial effusion, and the LV is dilated with very poor contractility. RV not grossly dilated. And yes, as Ezra rightly pointed out, there's this sign here of possible RV free wall collapse, which can be an indication of possible signs of tamponade. So what I want to do is talk about pericardial effusion and cardiac tamponade, and after that we'll come back to this particular patient. But thoughts on causes of the effusion in this particular patient? Anyone? So our thoughts, I'll jump in then. Our thoughts were, she's got lots of potential reasons to have a pericardial effusion. This lady's got end-stage kidney disease, and the family did note that she'd been becoming edematous over the last couple of weeks, and increasingly so. So she may have had a uremic pericardial effusion. The other thing we need to think about in the context of a STEMI is a LV or a myocardial rupture causing effusion. She's also had prolonged CPR. Could that have caused some trauma, causing her to have some effusion as well? But let's just now take a step back, and we're going to talk about how to assess pericardial effusion on ultrasound. And then we'll also talk about the signs of cardiac tamponade on ultrasound and how we evaluate that. So first things first, we'll go back to basics. Pericardial effusion, how do we assess it? First things, we want to check that it's actually a pericardial effusion, not a pleural effusion. The best way of doing that, as those who do a lot of ultrasound probably know, is we generally look on the parasternal long axis view and identify that descending thoracic aorta that sits here, this little round spot here. If the fluid sits anterior to that, it's a pericardial effusion. If, however, the fluid collection is posterior to the descending thoracic aorta, it's likely to be pleural effusion. And we can see in this second image here that this patient, in fact, has pericardial fluid as well as pleural fluid. So just being sure of your landmarks to make sure that you're actually looking at pericardial fluid rather than pleural fluid is the first step. The next thing we want to do is think about the size. So you're going to try and assess the presence and the size of this effusion in as many different views as possible. You ideally measure it at the end of diastole when the heart is relaxed. Pericardial fluid will usually lie in the posterior inferior part of the heart in the early stages because, of course, its fluid is dependent, and you're most likely to see that on the parasternal long axis and short axis initially. Once it becomes larger in size, over about 1 centimetre in diameter, it's more likely to become circumferential, and you'll be able to see it on all of the different views. Over 2 centimetres is what we'd call a large pericardial effusion, and that will obviously be likely to be circumferential as well. But we can also talk about the quality or the description of the effusion. It is possible to have a loculated or pericardial effusion where you're only seeing effusion in one area, and that's important to describe. But usually you're going to say it's either anechoic, meaning it's either fluid or fresh blood. It could be hyperechoic, for example, with coagulated blood, like on this example here, or it could be even fibrinous or loculated, anything else. But it's important to look at it and just describe what you see. So let's talk about cardiac tamponade. The basics of the physiology, just to run over that, to remind ourselves. The pericardium has some elasticity, but once that elastic limit is reached, the chambers of the heart have to compete with the pericardial fluid for that fixed intrapericardial volume. And the cardiac chambers become smaller then as the pericardial fluid becomes bigger. The diastolic compliance of the chambers is reduced, so venous return is reduced. And ultimately, this all leads to decreased preload of the left ventricle and a fall in LV output, which leads to shock. And it's an obstructive shock. So the physiological outcome of pericardial fluid it depends on how fast it accumulates. So if you've got something acute happening, as we know, you get rapid progression to tamponade because that pericardium isn't able to expand. If you've got chronic pericardial effusion, like in renal failure or like in malignancy, the pericardium can slowly stretch over time and can accommodate even up to 1 or 2 litres of fluid. So clinical findings of cardiac tamponade, I'm sure we all remember Beck's triad from medical school, hypotension, raised JVP and muffled heart sounds. But other important features are obviously dyspnea, syncope, and of course pulsus paradoxus, where we get a fall in the systolic blood pressure of the patient when they inspire. So important to always remember that cardiac tamponade is a clinical diagnosis, which is made in the presence of pericardial effusion. It really depends on that hemodynamic instability, and those severe symptoms is what really defines cardiac tamponade. So how do we assess for tamponade sonographically? So always important to remember that the sonographic features of tamponade often precede the clinical features. So we may have a patient with a pericardial effusion who's not particularly symptomatic, but we can still assess them for signs of tamponade, because if we start to see those, it's important that we get onto it and we refer this patient appropriately. So when we talk about tamponade, again, we go back to our physiology. The compressive effect of the pericardial fluid is seen in the lowest pressure chambers first, and in the phase of the cardiac cycle when filling pressure is lowest. So in the cardiac cycle during systole, that's when the atria are filling. So that's their lowest pressure time. And in diastole for the ventricles is when they're filling, and that's their lowest pressure time. And we're going to see those physiological hemodynamic features of tamponade in those phases. So let's talk about the right atrium to begin with. We're going to see collapse during late systole, and this is probably the earliest sign because this is the lowest pressure chamber. Looking at this image, you'll see this is an apical 4-chamber view. We've got that anechoic pericardial fluid surrounding the heart, and the right atrium here, have a look at this wall of the right atrium, and you'll see it's flickering in and out, and it's sort of collapsing under the weight of the pericardial fluid, essentially. It can be tricky to appreciate the cycle, the part of the cardiac cycle in which that's happening. It's easiest to do if you do have the patient attached to cardiac monitoring, and you can slow down the image and really have a look at what is going on in comparison to the ECG. So you can identify when systole is and when that collapse is happening. But that said, just looking at that image, if you look enough of these images of tamponade, you'll start to recognize that appearance of that wall just collapsing in on itself. And that gives you a good sign. This is an early sign that the pressure in the pericardial space is starting to have effect on the cardiac chambers. So now let's talk about the right ventricle, which is the one we think about probably most often. The RV free wall collapses in early diastole, and that's at the beginning. You'll see this best in the parasternal long axis, but also in the subcostal view, like this image right here. The longer and the deeper that collapse of that free wall, the more severe the tamponade is. So looking at this image here, you've got a subcostal view. Here's our right ventricle here. Here's our left ventricle. We've got pericardial fluid here, you can see. And see this appearance of this RV free wall just collapsing in on itself. Interestingly, just as an aside, you can see in that pericardial fluid there's something going on in there. I'm not sure what that is. I'm not actually, this is a one that I've nicked off the internet, but that's something to describe. If you're describing your findings to somebody, you're going to describe that there is something within the pericardial fluid, either a fibrinous strand, there's something going on. So let me just check that chat. Okay, so that's our right ventricle free wall collapse. Now, this free wall collapse can be difficult to fully assess, and we can use M mode to help us better assess the fact that the free wall is collapsing and also the timing of it. So M mode is something that we can often use best used in the parasternal long axis, but can be used in subcostal as well. And what we do is we place that M mode through the right ventricle and then through either the mitral valve or the aortic valve. By placing the M mode through the aortic or the mitral valve, it does allow us to appreciate where in the cardiac cycle we are by the movement of the valve, and we can see the collapse. So looking at this image here, we've got our M mode running through the RV and through the mitral valve here. Looking on M mode, what you have here is the RV wall here, the intraventricular septum here, the posterior LV wall here, and here we've got the movement of the mitral valve within the LV. Now we can see the E and the A wave of the mitral valve, and I'll just explain that for anyone who's not familiar with those terms. When the LV relaxes in diastole, the mitral valve opens, and often in a well-functioning LV, almost hits the intraventricular septum, and that's what we call the E wave here. When the atria contract, we get an extra little kick of flow through the mitral valve, and you see this little A wave here. So we've got the E and the A wave. So when the mitral valve is open, that's when we're in diastole. When the mitral valve is closed, we're in systole. So we can see on this image here, we've got our pericardial fluid on either side of the heart, this black anechoic area here and behind the LV here. And what we can see when the mitral valve is open with the E and the A wave occurring, we've got this collapse of the RV down here. So this tells us that we do in fact have RV free wall collapse during diastole, which is a sign of that compromise of those cardiac chambers, suggestive of tamponade. You can also do this, as I said, through the aortic valve, but you're just looking at diastole being when the aortic valve is closed and systole being when the aortic valve is open. What else can we look at? The IVC, of course. We're going to see in tamponade, as you know, we've got decreased venous return back to the heart. So the IVC is going to be dilated, plethoric, over 2.1 centimetres, and it's not going to collapse terribly well with inspiration. And we can look at that, measure it, and use M mode to check that collapse of that IVC if it is occurring during inspiration. So this is a more advanced technique to assess for signs of tamponade using Doppler. Not part of our standard assessment that we would do in our focused echo and life support, but is something that if your echo skills are more advanced, you can look at doing. So what we're going to do here is assess the velocity of blood flow across the mitral valve throughout the respiratory cycle. And we're using pulse wave Doppler in the apical 4-chamber view and placing that pulse wave just across the mitral valve. We know that we get small amount of inflow velocity change with respiration and a decrease of maybe 5% with inspiration is normal. But if we're seeing a decrease of more than 25% with inspiration, then that supports a possible diagnosis of tamponade. And this is essentially the echo equivalent of pulsus paradoxus, where we get that decrease in systolic blood pressure with inspiration. So here is what you will see when you attempt to do this. You've got the heart in apical 4-chamber. You've got your pulse wave Doppler through the mitral valve here, and you are recording an E and an A wave with each diastole with the flow across the mitral valve. And you should see that all of these complexes looking pretty much the same. But what we see here is you've got, looking at these peak velocities here, you've got a clear cyclical change with respiration. And by assessing the smallest and the largest one, if you can see there's a 25% change, again, that is a sign that you've got possible tamponade. So again, more of an advanced technique, but if it's something that's, you know, in your toolkit, you can certainly use that. So let's go back to our patient. First, does anyone have any questions or comments on that? Or anything they'd like to add? No? Okay, we will move on. But do feel free to jump in anytime if you've got anything to say. So looking at our patient who is in arrest, as this is back to our original image that we found here. We managed to put some M mode across the two chambers. As Ezra pointed out earlier, we couldn't really see the mitral valve adequately. And so using our M mode and identifying systole and diastole in this patient is more difficult because we can't really fully identify when the valves are open and closed. I'm having a look here at the LV chambers here. If we can sort of convince ourselves that this small contraction here is around systole and this relaxed phase here is diastole, when we look at our RV wall, we can see that probably there is this collapse during early diastole. And that's what, as Ezra rightly pointed out to begin with, having just recognized this appearance of this dimpling of the RV-free wall, that, yeah, we probably do have some RV wall collapse here, and it's probably occurring in diastole, and it's probably a sign that there is potential tamponade from this fluid. But we need to think about this in the context of this patient. So we do have pericardial effusion. We do have possible early sonographic sign of tamponade, but we've got a patient who's had a really big STEMI and a severely impaired LV contractility. So this is probably not sufficient to explain her arrest. We know that she's got pericardial fluid. We know that sonographic signs of tamponade can precede the hemodynamic instability, and we've got a really good reason for her to be arrested. So how did this lady go? As I said, she did not go very well. Her pH was awful. Her potassium was found to be 1.7 on her first VBG. It was thought that that was potentially a diluted sample from one of her pretty sketchy lines. Nonetheless, her potassium was replaced quite rapidly, and some bicarb was given to get her pH up above 7. Unfortunately, this had no effect on her hemodynamic compromise, or we did not achieve ROSC. There was a discussion with the family regarding her wishes, and the family felt very strongly that after such a long downtime, she would not want to live a life where she was impaired. Following those discussions, after a total of another 40 minutes of CPR in ED, there was a decision to cease resuscitation. And she had a total of about 1.5 hours of downtime, unfortunately, for this poor woman. So this was an interesting case because I think when we do a Fells examination, or when we examine a patient with ultrasound in this kind of situation, we're looking for reversible causes, and pericardial effusion is certainly one of them. Could this pericardial effusion with these early signs of tamponade have contributed to her loss of cardiac output? We don't really know the answer to that, but the feeling was, and thankfully at this time we had Dr. Kavi with us down from ICU, who's obviously an echo guru, and she was pretty comfortable in saying that, no, this is probably not going to contribute to her arrest, and that draining it would not probably reverse things. And looking at this patient in the big picture, we had a clear cause of her arrest with a really prolonged downtime and a highly premorbid patient. So she had little chance of meaningful recovery. So I wanted to talk about this case, as I said, for a couple of reasons. One, it was a really good chance to think about pericardial effusion and sonographic signs of tamponade and using that M mode. But secondly, also to talk about how when we find these features on our ultrasound, how do we fit it into the bigger picture of what we're seeing with our patients? And, our, urge to do something about what we've found when really we probably wouldn't have changed the outcome for this woman. Does anyone have any comments or things they'd like to talk about with this patient? Because I think it was a fairly interesting case, but if anyone's got anything to add, I'd be very keen to hear.
I think, Elise, like good discussion points, because you're right. When you look at the the actual tamponade, the size of it and the kind of effect it was having, I think, it's one of those things where you would probably do something about it if you actually have the right sort of patient and comorbidities. Sometimes, the decision is sort of affected by those parameters. But you could sort of say that in this patient, they're probably obviously quite a few different reasons for the hypertension and the cardiac arrest. But anything you can do to make it a little bit better, in the scenario you're in, would help. We had, for example, a baby, I think a toddler, 12-monther or something, up in the peds ward that actually had the tamponade from a very, very large pleural effusion, and then associated sort of cardiac effusion as well. So the moment we drained the pleural effusion, he got ROSC back, cardiac arrest. So obviously, that's an entirely different patient population, So it's it's one of those things where it's a pure obviously sepsis, as well as it was large empyema, full white out of the lung. So anything you can do to get some cardiac sort of activity back or some sort of function back is helpful. I think if this was a younger patient, for example, with comorbidities, you'd probably do it. You'd probably do a pericardiocentesis as a last resort. And in this case, obviously, the STEMI is the more important thing to get them up there. And if they're too unstable to go up to the cath lab, then you kind of have to do something, isn't it? So you have to decide based on the patient population, unfortunately. So I think in this case, I think the decision was the correct decision. I think, especially because the factors were the prolonged sort of downtime and a lot of comorbidities. So I think you couldn't really have done too much else. Dasim and I have done a pericardiocentesis in a case like this long time ago, where we had nothing to lose. So we just put the needle in and just tried to drain it. And it was then sort of subsequently found that it was futile anyway, because the patient had a dissection, which you couldn't diagnose, obviously, because the patient was in a cardiac arrest. So it wasn't very difficult. So it was very hard to do that at the time. But when he kept draining blood and it just made no difference, and then eventually you saw a flap and stuff, it was a sort of a bit diagnostic. But so I think this is a good case. It's one of those quandaries, isn't it? Whether you do everything or you're not, I think you have to decide based on family input, specialty input, and the patient's condition, really.
Yeah, it was an interesting case, and it played on my mind a little bit because we did see that effusion, and we did see that sign of possible tamponade. And I did wonder that, look, we're now in PEA, if we drained this, would we get enough output to get her to cath lab? But obviously it was a decision made by, with multiple people involved, including, ED consultant, ICU consultant, and family. And I do think it was the right outcome. After an hour and a half of downtime, this lady was not going to have a good outcome. But I think you're right, in a different patient with fewer comorbidities, with a shorter arrest, absolutely, you've got the patient's dead, you've got nothing to lose than to try and drain that effusion and see if you can improve that output. But for this patient, it was unfortunately not a good outcome.
Elise, can I ask, just in terms of draining it, I don't have any experience in this, obviously, but how does it kind of factor into your management of the cardiac arrest? Do you have to pause CPR and then do an ultrasound guided drainage of it? And how long do you sort of allow for a procedure like that?
That's a really good question, Jake. I've never done a pericardiocentesis in an arrested patient. Some of our more senior colleagues on the line, would you care to comment? Have we got Abra, Gabby, Lynn, Ben, Fran?
Look, it's, we did, when we did the pericardiocentesis, like that was the only one that I've ever done. And it was really in a case of futility, really, sort of going all out, and you can't really do it really well when someone's doing CPR. I think the possibly the best thing you can do is to have like a Lucas device on, and then you time it. But really, every time that Lucas device pumps down, your needle tip's going to go somewhere else. So it's really, really like dangerous. So really, I think it's one of those things where I think it's like essentially like you're throwing the kitchen sink at everything, and that's really when you do it. But to be honest, you need some sort of like you need ROSC, you need something even temporarily to be able to put a needle in. I don't think you could do it in ongoing CPR. I think it's one of those things where, like, the teaching is, and I think it's right, that good quality CPR is important. So like stopping the procedure from that is like not going to help. But when we have trauma patients, in trauma patients, you would actually do it. You would actually see CPR. You'd go in and you'd put a needle in and do it. So that's a different scenario. So a tamponade in that sort of a scenario would be treated just like you would if they have a bleeding artery, or if they had a hemothorax or a pneumothorax. You would not be doing CPR anyway. You stop everything and you just get that blood out. So, but that's like a different scenario. But I've, in a case of a like non-traumatic cardiac arrest, I don't think you would do it.
Okay. Or I wonder if if you put the probe on and you go, oh, there's a massive pericardial effusion, we think that's the cause. Do you go, all right, we're going to make the decision to pause the CPR and drain this just because it's so big that it's likely the cause of the cardiac arrest?
Yeah, I guess you could. It's one of those things, I think, without being in the scenario, it's hard. I think there's no right or wrong answer. But yeah, I think if it was a really large one and you think that, we'll just give it a shot anyway, you would. It's kind of like how if you see a PE and stuff, you're just going to thrombolize. If you see some signs in the patient's in a cardiac arrest, you'd give it a shot. So yeah, you could. I think it's a kind of decision you have to take in the moment with people that are with you, like at the time. But I can't sort of say, like saying here now that, I'll do that every time. I think, it's a hard one. It's a tough one.
Mm-hmm. And certainly in this particular case, as you saw from the images, it wasn't a big pericardial effusion. So attempting to drain that with CPR ongoing would be extremely challenging because there's not a huge pocket of fluid that you're aiming for. So that makes the degree of difficulty significantly higher, I think. All right. So we might move on to another case. So I've got two more cases. We're not going to go into them nearly as deeply as this one. We're just going to talk through two little fun cases of nice use of POCUS in the ED. The first one is a renal one, just because we talked about renal tract ultrasound last month. So I thought it'd be nice to just follow up. Sorry, before we move on, this is just, a bit of a summary on assessing patient with pericardial effusion, describing the location, the size, looking for your sonographic signs of tamponade, and most importantly, looking at the patient and their hemodynamic status. I've just added a little quote from an old colleague from Sydney here, who's a bit of a ultrasound guru. And she said, seeing a pericardial effusion is easy using ultrasound, but being able to describe it's important. Avoid using the term pericardial tamponade unless the patient is in shock and there are real echo features suggestive of tamponade. The best way to describe an effusion is by describing it systematically, along with any hemodynamic features on echo suggestive of compromise. So just keep that in mind when looking at effusions and assessing patients with pericardial effusions. All right, so next case. So this is a 48-year-old female. I think this was Tim's patient, managed expertly, who presented with left flank pain similar to her previous episode of pyelonephritis. And she was febrile and tachycardic in ED, had a urine forward test that was consistent with the UTI and had no previous known history of ureteric calculi. She was planned for an SU admission for some IV antibiotics overnight, and a CT-KUB had been booked just to rule out obstruction, but that was in a non-urgent sort of way. Tim asked me to do a little bedside ultrasound, I think more for my education than anything else, but here's what we found. So the right kidney, we can see a nice looking kidney here, which looks pretty normal. There's possibly a slight dilation of the renal pelvis. I can't remember looking at this, whether this might have actually been a vessel when I put colour on it. But the most important thing is looking at this left kidney here, which looks significantly different. You can see that we've got significant dilatation of the renal pelvis up into the calyces and almost all the way up into the pyramids as well. Certainly highly suggestive of obstruction. I also had a look at her bladder and put colour Doppler over looking at the ureteric jets, and there was not a single ureteric jet coming from the left-sided ureter in her bladder. So how did this change our management? There was an immediate change in disposition. Instead of going to SU, Tim was able to make an early referral to urology and start planning for a possible nephrostomy later that evening, and expedited her CT KUB rather than waiting in SU for many hours. And she was found to have an 11 millimetre obstructing calculus. She went off to have a nephrostomy later that evening and slowly got better over the course of her admission. Our next case is another fairly straightforward case where we were able to use POCUS to make an early diagnosis. A 72-year-old man who presented with shortness of breath, chest pain and abdominal pain, had a background of COPD with multiple recent admissions, but also had a history of a recurrent right pneumothorax that had previously required pleurodesis. He'd been managed as a COPD exacerbation by AV and was sitting in Resus 1 awaiting review. Now, this was an afternoon where we had 2 simultaneous resuscitations going on in Resus, 2 patients being intubated at the same time, one of which was a child. And so this gentleman was probably slightly down the list in terms of urgency of review. Darcy and I happened to be just loitering around looking for work and spotted this gentleman who looked pretty dyspneic. His SAPs were a little bit suboptimal on nasal prong oxygen. He appeared a bit tachycardic at about 120, but blood pressure was holding. Just because I was nosy, I opened up his chart and found this history of a pneumothorax in the past, and we thought we'd better go and have a look at this man's chest. So we had a look at his right and left lung. You'll see his right lung. We've got some lung sliding here, slightly irregular looking pleural line, and we've got a couple of B lines in there, but certainly we've got lung sliding. We moved over to the left side of his chest, and here is what we found. So we cannot see lung sliding here. We've got some A lines, which is just normal reverberations, an artifact from our pleural line. But you can see it looks very different from the other side. So he's not got lung sliding, highly suggestive of a pneumothorax. You can see by the movement of his chest wall that he's pretty dyspneic. He's actually quite tachypneic. So we knew this man had a pneumothorax. As part of our examination, we noticed on the right side of his chest that we could see cardiac movement. On the left side of his chest, we could not see cardiac movement. So this man now has a pneumothorax with signs that his mediastinum is actually sitting on the right side of his chest. So what did we do? While we were gathering things to get ready to decompress this man, we did what you should never do in a tension pneumothorax, is get a chest x-ray. No, the radiographer happened to be in the resus bay next door, having just finished doing an x-ray to confirm tube placement. So she was called over very rapidly to see if we could just confirm our findings. And this is what we found. We found a tension pneumothorax. So we can see we've got a big pneumothorax on the left. We've got the mediastinum shifted to the right. And we've got a man who is pretty unwell. So as we were getting our tools together, the radiographer sat him up to do this chest x-ray, and he did feel quite dizzy and had briefly decreased level of responsiveness around that time of the chest x-ray. But our resus consultant was right there at the bedside, rapidly decompressed him, and the patient felt a whole lot better afterwards. So another pat on our backs for POCUS in the ED. All right, those are the end of my cases for today. So next thing is we're going to move on to Journal Club. But before we do that, does anyone have any comments or things they'd like to add or cases they'd like to talk about?
I was just going to ask Elise, did this gentleman have a pleurodesis on the right side for his recurrent pneumothoraces?
He had a pleurodesis on the right side for recurrent pneumothoraces, but from what I could see from the notes, he hadn't previously had a left-sided pneumothorax.
Yeah, no, that's good. Thank you.
Okay, so if no one has anything else to discuss or any cases they'd like to talk about, we can move on to Jen.
Yeah, let's do it.
So. All right, can you see my Journal Club screen, guys? No.
No, it seems to have sort of frozen as it was minimizing.
All right, give me a moment. I'm going to stop sharing. All right, can you see that?
Yep.
Fantastic. All right. So this is a quick, fairly simple little study, but I thought it was kind of interesting. The parasternal long axis view in isolation, is it good enough? And the authors of this study, which was published in Journal of Emergency Medicine last year, sought to do a study to ascertain whether or not the parasternal long axis by itself gave us enough information to make diagnosis of important pathology as compared to a 4-view focused echo that we would normally do. So a little bit of background, transthoracic focused cardiac ultrasound, which they refer to as FOCUS, and it's what we might refer to as Bell's or FELS, focused echo and life support, where we obtain our 4 standard views, the parasternal long axis, short axis, apical 4-chamber and subxiphoid view. And we aim to identify pericardial effusion, LV systolic function qualitatively, and any evidence of RV dilatation or right heart strain, plus or minus any other pathology we might happen to see along the way, including fluid status. So the 4-view approach, advantages are many. It provides different perspectives to evaluate different kinds of pathology. If we see pathology on one view, we can reassess it on a different view to get an adequate understanding of what's really going on and ascertain whether or not we've actually got pathology versus artifact. And we also know that certain views are better at identifying specific pathology compared to others. So we may look at apical 4-chamber ideally to assess RV size in comparison to LV size. We know that subxiphoid or parasternal long axis are good for effusions, particularly the ones that sit posteriorly or inferiorly. The disadvantages of the 4 views is that it's tricky. It's quite hard to do in a lot of patients, those with COPD, those who are obese. Obtaining all 4 images is quite hard. It can be time consuming, particularly for people with less experience. And they portend that because it's so challenging and it can be time consuming, it discourages novices from even attempting to get these views. So the goal of this study was to ascertain, well, what is the diagnostic accuracy of the parasternal long axis view in isolation for identifying those 3 sort of primary pathologies, the pericardial effusion, LV systolic dysfunction, and RV dilatation, as compared to a standard 4-view examination. So this study was performed across 3 urban academic EDs in the US with a combined volume of patients of more than 280,000 presentations annually. And it was a retrospective study of images acquired from 100 focus examinations performed by ED physicians across those 3 centres. So how did they choose the sample? In an interesting way, the sample of examinations was chosen from all focus exams logged in a database between January 2016 and December 2020 over a 4 and a bit year period. And 100 examinations were selected by a single clinician who has extensive experience with focus. And this clinician chose these 100 examinations based on them having good or excellent image quality and having all 4 standard cardiac windows imaged. The clinician excluded low quality examinations or incomplete examinations and chose a sample that contained both normal and abnormal findings. So what they did, they had these 104 view examinations and recruited 3 reviewers who each interpreted a third of the exams, so to develop a gold standard. So each reviewer examined about 33 exams, interpreted the findings, and these were used as a gold standard. They then duplicated the parasternal long axis view from those examinations and provided them to 2 reviewers, and each reviewer reviewed all 100 exams and interpreted them. So all images that were reviewed were interpreted for presence or absence of pericardial effusion, a qualitative assessment of estimated LV ejection fraction, being normal, depressed, or severely depressed, and for RV dilatation, the presence or absence being defined by an RV-LV ratio of more than 1, or for the isolated parasternal long axis views for a ratio of more than 1 for RV compared to the aortic outflow tract and the left atrium. So each of those, the 4 view exams had a single review that was the gold standard, and the parasternal long axis only exams had dual review, and if there was discrepancy between the interpretations, a 3rd reviewer served as a tiebreaker. The reviewers of the parasternal long axis images were blinded to the interpretations of the complete exams, and these independent interpretations were recorded on standardized data collection forms. The primary outcome was the sensitivity and specificity of the parasternal long axis view alone for detecting pericardial effusion, LV systolic dysfunction, and RV dilatation. So here are the results. So of the 100 focus exams, there were 16 pericardial effusions, 39 studies showing LV dysfunction, and 7 studies showing RV dilatation. Based on this, they calculated reasonably good sensitivity and specificity for detecting pericardial effusion and LV dysfunction when using the parasternal long axis views alone. The sensitivity and sensitivity for detecting RV dilatation was not as good, with a quite wide confidence interval there. So the disagreements between the parasternal long axis and the 4 view exams. Of the 16 pericardial effusions, the parasternal long axis missed 3 effusions, which were all classified as small on the 4 view complete examinations. The parasternal long axis images identified 2 small effusions that were deemed absent on 4 view exams. Of LV dysfunction of the 39, the parasternal long axis identified 5 as having moderate to severely reduced LV function, and all were in fact classified as normal on the 4 view exams. And as for RV dilatation, parasternal long axis missed 1 RV dilatation and identified 2 dilatations that were normal on 4 view. So how do we really summarize that? That parasternal long axis in isolation was pretty good for identifying clinically significant pericardial effusion, pretty good at identifying LV dysfunction, but might have overcalled it a little bit, and was okay at identifying RV dilatation. So based on this study, should we abandon the 4 view exam in favour of an isolated parasternal long axis view only? Thoughts? I'm going to say no.
Yeah, I'll say no as well.
Yeah, a few small problems. Look, this was an interesting study. The numbers are small, so it's 100 studies. So the pathology numbers are pretty small. As you see, there's only 7 studies that demonstrated RV dilatation. So it's a little bit tricky to really get an accurate sensitivity and specificity based on those small numbers. The sample selection also is probably not reflective of real life. These exams were specifically selected because they were high quality in all 4 views, which is very useful for the purposes of this particular study, but it's not reflective of real life of the patients that we see day to day on the floor. There's also potential for bias as well. We've got a single reviewer who selected these studies, and they're hand-picked studies. So you, of course, if you're trying to prove that the parasternal long axis is really, really good, you're probably going to pick the 100 studies that have really, really good parasternal long axis views. So lots of potential for bias there. The interpretation of the images as well. All of the reviewers had quite a lot of expertise in ultrasound and echo, high-level qualifications. And again, that's not really reflective of real life. We have a lot of people that, although maybe accredited to do a focus or a FELS examination in ED, don't have that expertise. And so it's likely that that the accuracy of the interpretations that occur in real life are not going to be as good as the interpretations from these people. So I thought this was an interesting study. It's the first attempt to study this. And I think the single view has its place, as in cardiac arrest, as we've just talked about earlier today, and as well as in trauma. But absolutely, we would encourage acquisition of all 4 views for many reasons. But, largely every patient is different, and some patients, it's going to be very easy to get one particular view and impossible to get others. And searching for all of those 4 views to get as much possible information as you can to help you with your diagnosis and with your management decisions is going to be beneficial for the patient. 4 views, even if you can get excellent views on all 4 views, it allows you to better assess the pathology that you do find and to better ascertain whether or not you're seeing pathology or artifact. And of course, doing, one of the reasons they said maybe we should just be doing a single image only is because for some people it does take a while to acquire those 4 views, and it's hard. But I would counter that by saying the more practice you do, the faster and the more accurate you get. So that's a problem that we can overcome by simply practicing more and doing more. Excuse me. So while this was kind of an interesting study and does tell us that the parasternal long axis does give us an awful lot of information, and I think we can all agree, those of us who use it, it does give us a lot of information. But I think getting all of those 4 views is particularly important. I think if they were going to try to repeat this study in a better way, we might do something prospective where we're using consecutive focus exams and reviewing those for the parasternal long axis and getting a proper accurate sample of what we really do find in the ED. Any comments, issues to raise?
Hello, Elise. David here. I think the point you make about trying to get all the views is actually a very good point, because as you said, it's going through the motions and practicing to become an expert at acquiring all the images. And that actually for a learner like me is the game changer, because if I get stuck with just a parasternal long, then I will not even attempt to get the other images and I may not become more proficient. So the process of going through all the motions to get all the images actually hopes to improve the image quality and also help one to become an expert. So I think I agree. Maybe the parasternal long may be easier to obtain initially, and that may be my go-to, my first start, but certainly not to end there, but to attempt to acquire all the other images and become better at those. So that would be my comment on that. Thanks.
Yeah, absolutely, David. I agree. Going through the motions of trying to acquire all those images is so important, and you only get better at it over time. And yes, in that learning phase, you do go through this fairly horrible phase, which I've most recently been through, where what you're doing is trying to acquire the images. The interpreting of the images does come second at that phase, because all you're really trying to do is get all of the bits on the screen that you want to see. And then ultimately, that interpretation of that image comes a little bit later. So I think it's just an important process to go through. You just have to do the work to get better at those images, and you do get faster at it, and then you are able to more easily acquire the images, interpret them, and add to your patient care in that way.
Awesome. Thanks a lot, Elise. It's an interesting study. And I I found that, yeah, I think this kind of a thing with one view definitely has a sort of place. But as David mentioned, yeah, just the practice is important, and sometimes confirming what you see in another image helps you when you're sort of starting out as well. So that's good. Thank you. If there's no other questions, I think this is the end of our general talk. Is that right?
Yeah, I think so.
Yeah. No worries. Thank you, everybody, for joining us. I'll stop the recording now.
Great.